Thank you very much, Lisa. It's a pleasure to be here. I'm going to do this in 2 minutes, hopefully. All right, let's look at the data for Alvimopan. These are my disclosures, not relevant to this talk today. So as we all know, Alvimopan is a peripheral acting mu receptor antagonist. It was FDA approved in 2008. It has been shown to accelerate the gastrointestinal recovery after colectomy. Usually it's given 12 milligram 30 minutes to 2 hours prior to surgery, and 12 milligram BID up to 7 to 15 doses. So there has been multiple data out there, randomized control trial, retrospective. What we have seen in an open surgery, open bowel resection with no enhanced recovery pathway. As you can appreciate here, the results has shown that it has decreased length of stay and return of bowel function. So in this case, Alvimopan is recommended to hasten recovery after open colorectal surgery with no enhanced recovery pathway. Now look at open bowel resection with enhanced recovery pathway. There has been studies, I show the two studies that are out there that were a significant number, and as you can appreciate, it has shown to decrease a length of stay in both of these studies and many out there. So Alvimopan in open surgery with enhanced recovery pathway has accelerated recovery of GI function. It has shortened the length of stay, even in an enhanced recovery pathway. Let's turn gears. Look at MIS. So bowel resection MIS with no enhanced recovery, there's been retrospective, mostly retrospective studies out there. And in studies by Delaney and Steele, which have one of the highest number, it has shown to shorten the length of stay right here and has supported the use of Alvimopan. So in an MIS setting with no enhanced recovery pathway, it has shown improvement to reduce length of stay and return of bowel function. But what if you have the enhanced recovery pathway? Study by Bartlett and Kelly, they have shown that in enhanced recovery pathway, it's questionable that if this really helps, with the return of bowel function or any difference in the return of bowel in length of stay. There was one retrospective study by Kelly et al. In 2013 that they did actually see decrease in the length of stay of their patients. So it's a little questionable, but as we can see, there is no great, support to say, in an MIS and enhanced recovery fashion, Alvimopan will work. And this is for the ostomy reversal, is a single institution, which has shown that is beneficial and help with reduce of length of stay. I'm, for sake of time, not going to go through, but here, as we can see, in different setting, in our conclusion, open, no enhanced recovery, helpful. Enhanced recovery, still helpful. Looking at MIS with no enhanced recovery pathway, it reduces length of stay, has been helpful, but in enhanced recovery pathway, questionable. For our ostomy reversal, it has been helpful. So these are the references, and hopefully we did it in less than 2 minutes.
Guzman with anesthesia over at UT.
Thank you so much for hanging out with us today. And I am here to let you know that, let me see the slides. There we go. So, yes, I have nothing to disclose except that I'm an advocate for patient care and fixing their pain. Why do we treat pain? That's what I'm going to concentrate on. And as you can see, this is quality of life has to do as well as outcome. Pain is the enemy of same-day discharge from the hospital because of the response, the stress response the body goes through, and the patient suffering, insulin going up, resistance. But given the fact that the physiological and psychological response to pain is so impactful in the outcome, regional anesthesia has to be part of the protocol for successful same-day surgery discharge after minimally invasive colorectal surgery. Transverse abdominis block has been proven to work since 2001 when it was described. Since then, it has evolved into other facial plane blocks, like QL block, as well as subcostal plane block. They all block in under the transversalis fascia. Of all these blocks that have been described, the quadratus lumborum plane block is being the most successful, managing, helping with the pain postoperatively, because it has posterior spread into the paravertebral area, and the patient develops a denser block. Not only denser block, it lasts longer, and then you have a sympathetic block, which helps with the visceral pain. So unlike the amlodipine, which has no impact on pain, and it has no data saying that it has no value on the outcome of laparoscopic colorectal surgery. If I went through the research, there is a lot of the evidence sustaining that, and also the research data and the clinical experience that I have, not only myself, but in the center that I work, where we have done in the last 10 years over 24,000 TAP block and QL block. We have that may be done with local anesthetic, short-acting local anesthetic, or longer-acting local anesthetic. It is consistent providing analgesia, minimal humoral stress response to surgery. It reduces the opioid consumption and improves the outcome, and therefore the patient will be able to be discharged home and same-day surgery after minimally invasive colorectal.